Those are our speakers, and we have Gail Zahtz coming up now. Gail is the president and CEO of Wise Care, and she's on the front end of what's going on with value-based care. So, Gail, are you ready? She's ready. All right.
I need a stopwatch because it's a really tight schedule. So, hi, I'm so happy to be standing in front of you guys. I mean, I dusted off my suits, right? They actually still fit after 2 years of COVID, so I'm super excited. I got like some height on my shoes. Jim was like, can you fly down? So it was tough because right now my backyard has 3 inches of ice, and it was tough to convince me to come down to Arizona in the middle of that. But you know, I persevered. So I'm also super happy to be standing in front of you because I spent 5 years in an electric wheelchair. And 5.5 years ago, I was getting sicker and sicker, and they couldn't figure out why. And I had an amazing medical team, right? They couldn't figure out why. And at one point during that, I said, what have we not done? Should we do a mammogram? And they're like, oh no, you're way too young for that. That's not it at all. And I'm getting sicker and sicker. Labor Day weekend, 5.5 years ago, I ended up in the hospital. Now, I'm in healthcare, so follow my thinking. I thought, I'll go in Labor Day weekend. The staff won't want to stay because it's Labor Day weekend. They'll check me out, check me home, and I'll come home again, right? And I knew I was getting sicker and sicker. I was having, like, right, my body's falling apart. And I get in to the hospital, I'm in the hospital, and they said, so we decided to transfer you to hospice. Okay, so I'm a single mom of 4 children. All of my children were still in school and home. There is no father, there is nobody else. And I said, hospice? I'm not going to hospice. Now, I love the people in hospice. Like, I honor the people in hospice. This is not like amazing work. It was just medically not my time. So because I'm in healthcare, I knew that there was a bed utilization social worker watching my bed, right? So I did a sit-in. I said, I'm not leaving. Now, I couldn't stand up. But so they bring in security with a wheelchair. But I know they can't touch me. So they're standing there like, man, we really need you to get into this wheelchair for the transfer. I said, nah, I'm not going. So they brought in a psychiatrist because they thought the problem was that I wasn't being compliant enough and accepting my situation. An hour, right, that I needed to meet with the psychiatrist, and he's like, you know, it's time. I said, nah. And he said, you know, write letters, you can write letters to your kids, maybe we can do some video. I said, nah, I'm not going. So 6 days, that bed utilization social worker who I never met said, get this person out of the bed, right? I'm running up those billable hours for the hospital. So I got a grand prize of being transferred to a 1-star SNF. So I'm in the basement, all concrete. Maybe it was never a room. Maybe it was just like set up as a youngest by decades. I had no immune system, so at the time it was a big deal that everybody had to wear masks in order to come in. Completely isolated, to be perfectly honest. And I'm in an electric wheelchair. I'm on liquid-only nutrition. I couldn't eat. I couldn't transfer myself. Nobody was allowed in and out. And then I get a call from scheduling, right, because transportation would come and pick me up at the skilled nursing facility and take me to the hospital. And the doctors had said, we got you in with the very next oncologist tomorrow. He's great. I said, oncologist? Do you mean I have cancer? And she says, no one told you? And I said, all right. So I go in, and I have an amazing team. It was a team that does a group. So I had a palliative team and I had an oncology team. Each team had a social worker and a nurse and a doctor. And the way they set it up was I met with all 6 on that very first day. And I said, here's the deal, I'm in healthcare. And I'm not gonna Google it, and I'm not gonna call my colleagues for a second opinion, and I'm actually gonna do whatever you tell me to do, but you need to know that I'm in this to survive. And we're not gonna discuss me dying, and I'm not writing letters to my kids, but I'm advocating for myself. There was no spouse, there was no parent, there was no adult child, and as I'm going into the offices all the time, you know, there's 2 chairs, one for the patient and one for the caregiver. So when the doctors come in and say, we want to tell you about, like, you're going to have this new 15-hour surgery or this new I'm spending the whole time looking at this empty chair, right? And people talk a lot, like, what enables us to survive what seems to be the unsurvivable? And my children, of course, I mean, number one, my children, me looking at that chair, right? A career in healthcare, and I'm looking at that chair, I said, it doesn't have to be this hard. It doesn't have to be this hard. I'm gonna survive so that I can help other people, that they don't have to be looking at this empty chair for everything that they're doing. And that kept me going through 10 months of chemotherapy. I had weekly chemotherapy, 5 rounds. The last one, for those who know, is called the Red Devil. It's actually a synthetic mustard gas. It was amazing. So it goes, I later learned that 50% of the patients actually don't survive the treatment. And I'm on the floor, like screaming. Like, it's hard to explain how much pain it is. And they're like, do we want you to stop the treatment? I said, no, I promised my son I would do every single treatment. I had a whole bunch, I mean, I had maximum amount of radiation. I had some courageous medical team. You know, the tumors had metastasized, they were in the lymph nodes, they were all over, going up the brain. And they got me to the point where they could legally operate, and a super courageous team that said, we're gonna do it. I was gonna lose my left arm because I had no circulation. And so after they were able to get all of the tumors, and I had no evidence of disease, and then I started the radiation and everything else. Remember, I'm living in the basement of a nursing home alone. Oh, with mold coming down from the ceiling, like dripping down from the ceiling. And I advocated, I called for the ombudsman. I'm in healthcare. I kept meeting with everybody, and they're like, there is nowhere to transfer you. There is nowhere. This is, you know, I'm like, so it's not a matter of being educated all the time. It's not a matter of knowing oh, that's my timer. I have to stop talking. Oh my gosh, okay. So.
2 minutes.
Thank you. I started walking again. It took me an hour to take my first step. I had my own transplant where we took from my stomach, right, so that I could save my left arm. I am left-handed, was super excited. Having that, because my body was so run down, it didn't heal, and I had an open wound in my stomach where they took it for 6 months. You could put your hand in my stomach up to your elbow for 6 months. It was completely open. The wound vacs weren't working. By then, I had gotten into transitional housing, and they had given me back my kids. So I had no spouse. I had a 10-year-old. And they're like, you need all of you need to take care of all the time. We can't give you 24/7 home nursing. And I said, I don't have anybody here. They said, well, we're going to send you back to the nursing home, and we're going to send your kids back to care. My 10-year-old said, I can do it, Mommy. And they said, okay. And so my 10-year-old did my IVs. Like this, right? For 6 months, I'm walking around with a wound vac and an IV pole. The short answer is that, one, I got amazing survival skills that I'd love to talk to you about, but I don't have the time. The quick thing is, show up, do the next right thing, find joy, dance often, and love fiercely. We all have that. Every one of us has that ability. And the other is that I saw this all through the patient lens. What it's like when you can't get transportation. What it's like when you don't get your medication. What it's like when you have a great medical team and the medical team doesn't know that they accidentally went to send you to hospice. The doctor said that was never supposed to happen, right? So that's what I bring today to everyone, is that view, right? Of the finances and also what it's like on a day-to-day. And everybody who's been showing up at the hospitals during COVID, everybody who's doing, like, amazing. Thank you so much. Like, I honor all of you for doing this. Thank you so much. I'll be back on in a minute. Thanks.
I was at a meeting yesterday with some Native American representatives, and I thought it was interesting that they, part of their culture is a story. You know, that you need to have a story, and that's really what starts the conversation. And so I'm glad that you got to hear Gail's story as to start this conversation. Gail, you want to come back up here and talk about surprise billing now? It's very, very compelling. So yeah, so Gail also has some time here to help us with some of the big news stories. You ready to do this?
Yeah, I'm ready.
All right, so surprise billing. Let's give Gail the mic because my voice carries. There you go, step up.
All right, 2 minutes on surprise billing. If you want to talk about it, you have to let me know. So if anybody knows, it passed in 2020. In December, Congress passed the No Surprises Act. It then went to the House, and then it sat with HHS for about 9 months. So many of you might have thought that it was not going to start January 1. Surprise! It started January 1, and you're all accountable, actually, to follow the law, even if you may not know what it is. The short answer is that the goal is that a patient should never again get a bill that they did not consent to. But that means everybody has to change the workflow because you've never been doing that before. How much does it cost? What is it going to do? It impacts out-of-network billing. It does not impact MA or VA, but over 200 million beneficiaries that you see have to get 72 hours before seeing anyone. And that actually includes anything. The blood vials can no longer go to an out-of-network lab. You can no longer call in the anesthesiologist when you're overbooked. If you do any of those and somebody accidentally gets a bill, it's $10,000 fine for every bill. And then what do you do if you don't get paid from the payer? It's super payer friendly. It is all 100% of the responsibilities on the provider and the provider groups to implement all of this as of 6 weeks ago. And then it just goes to arbitration. 50 new arbitration offices have been set up nationally, and the arbitration will always only pay at the most the medium middle rate of what it would have been to be in network. So for all of you who are connecting the dots on this, your absolute best way to do this is to create in-network prices with everybody. And the very first thing before you fix it with your technology is fix the technology of sending bills. Because see, perfect timing. I'm excited. Okay, go ahead. You can ask me after, I can talk to you.
That's just surprise billing. You have more to talk about. But I want to make a quick announcement. I've been talking about this for years too. I think this is on the providers. If you're a hospital and you have a staff, then you should control who's on your staff. And they should not be seeing people that are out of network. You should not have surgeons that are doing surgery that are out of network. You should not have anesthesiologists driving by and sending a bill later as a surprise. So let's clean this up. What about Mips and reimbursement?
Funny you should ask, Jim. All right, 2 minutes. All right, for anybody who doesn't know, the total reimbursement reductions that have occurred this year, January 1, you're going to be seeing a total 20% less on your provider when you get paid in the next couple months. It starts January 1. MIPS conversion rate actually went down for about the first time ever, which means that the basis of all of your payments are going to be lower than they were. But when you then add the fact that the value-based payment, there was a carrot that CMS put out for years of 2%. And that 2%, I know, was your profit to be able to pay for the nurses and the paperwork and the quality reporting. CMS, that is gone. That is not coming back. Then there's also a reduction in a whole bunch of other payments, which we don't get a chance to talk about, but you're looking at about 10% reduction, 9.7% total in what you're getting your providers. You add that to the fact that we all realize that you're going to pay less money because of the Act, and you're looking at about 20% less on your providers. And this is not future talking. This is when you open your money in the next 30, 60 days, they're going to be less. And so everybody has to plan for how you account for that and manage that. So I'm not good.
What about this executive order?
Okay, so the executive order is something that you're going to see for your patients. So I wanted to put that in there. They actually came from the president's office. They required a whole bunch more of consolidation. So for those of you who know that what we've been working on One Stop for literally over 20 years, is actually now there's going to be one site for VA, one site for Medicaid and CHIPS, where people can get all of their social determinants. You'll have to ask me. He was worried I would be too talkative.
Infrastructure bills.
Yeah, money's coming to Arizona, but you have to capture it right now. So in the infrastructure bill that's already passed, there's 2 infrastructure bills. They now call the second one Build Back Better, but the first infrastructure bill that already passed is bringing a tremendous amount of money here to Arizona that we can capture now. But what you're going to be looking at is broadband everywhere. There's about $3.5 billion allocated to broadband in Arizona. Sanitation, $5 billion on the reservations for water and roads and sewage, which means that you can connect that to clinics and care. You're also looking at money for specific roads, which as a health system, you can appeal to get some of that money to give your patients access to your facilities. Rural goes first. All the money goes to rural first, and in Arizona to the reservations. So start thinking about how you can access that, because I will tell you, this money is only going to be around for a really short time. And then the second bill that we're waiting to get passed, you're going to see a lot more of daycare. You're going to see CHIP expanded, which is going to affect a lot of kids and parents here in Arizona. We have not yet seen the support for our health systems that we'd like to see, but that's it. I'm going to
All right.
ask the manager.
All right, what's next? Telehealth. All right, so telehealth grew like crazy, right, in 2020, but now there's regulations. Now it's like, okay, now it's time to tighten it up. So what's the government doing here?
So, period, everything was on a waiver. It was like CMS did 8,000 telehealth waivers during the first 60 days of COVID, which hats off to the people at CMS who did it. But those waivers are all expiring or will expire when the emergency ends. So people have been trying really hard. Okay, that was a different timer. They've been trying hard to get it expanded, and the expansion, I know it's a shocker, is a little odd, which is they have expanded the telemedicine reimbursements for only 2 conditions. But if you put that as a primary condition, it's covered. Musculoskeletal and sort of like some of the cardiac stuff. But if you claim that as your primary, not your comorbid, the other is that makes it really interesting is that with those 2, it doesn't have to be a doctor. So you can now have your physical therapist for those 2 conditions. You can have physical therapists, dietitians, but they took away the ability to have that person remote. So the supervising provider has to actually physically be here in Arizona, which is different. And they also expanded mental health. So mental health can now be audio. It's the only diagnosis where you're allowed to do audio if they've already seen somebody in the past year.
So that's phone.
That is
phone call.
That is phone.
Yeah.
That is phone. Well done, you.
Yeah. All right, so again, these slides have lots of information. We're not going to cover everything all the time, but you can go back and look at these slides for more details later. And then the last subject for this section is this pivot to value-based care. And one of the questions I asked early on during the pandemic is, are companies that took capitation or that are on some sort of prepaid system, are they doing better during the pandemic? Because we saw this loss of revenue, and all the fee-for-service providers are freaking out because their volumes went down. So what's the trends there with people getting into value-based contracts?
Yeah, so what's interesting is the trends where you guys had plenty of volume, right? You had the thing was that your volume was not where you had profits because all of your elective surgeries ended, and so the question is the people who were during the pandemic were just receiving money that they could count on. We're going to be talking towards the end about the entire strategic refresh, There's huge, huge news. I'll give you the punchline. We are absolutely 100% moving to value-based care for everything. And if you're waiting on CMS, which CMS is saying they're going to do it by 2030 now at the absolute latest, the employer self-pay plans have already announced that they're moving ahead this year with contracting. Direct contracting's reopened. So we're going to talk about it later, but I do just want to say this is no longer me standing, and I've been standing in front of people for a lot of years saying this is going to happen, and they're like, yeah, we're not even listening anymore. It's actually happened. Like this year, you actually have to plan, and your tech systems absolutely have to be up on the data requirements and the quality reporting this year, because it's phasing in some 2022, some 2023.
And we have an industry here, we have a pretty dynamic industry of ACOs already doing this, and so this is where I stuck the ACO data. So for you wonks that want to know all about the ACOs, we've got a few slides here. We're not going to go into them now, but we have had some successful ACOs that have cashed checks from the federal government. Some not so much, but some a lot. That Steward score that's a nationwide ACO. That's not all Arizona. Our Arizona All-Star is Innovation Care Partners. They've cashed checks every year for the last 5 or 6 years. So we've had some success there. That is a reference page in your book. And then this is the tracks that they're in. So they're moving into higher risk tracks. They're moving out of the low risk tracks. And so we are seeing this happen in Arizona. So it is real, but if you're not on this train yet, you're probably late. So thank you very much, Gail. Gail, you've got it. You've got the podium for the next 20 minutes. Or 19 minutes, actually.
No, 20 minutes. But I am, which is my street, which is my name.
You can have that.
Look at this. But I am going to take a minute out of my own time. And I know it's super awkward, but I'd like you guys to stand up. While you're standing up, I travel all around the country. I spend all of my time looking at all of the numbers. Arizona, you're rocking it. Give yourselves a hand. Seriously, you guys are doing an amazing job, and I know it's been a really hard couple of years, so I want to take time out, really think about everything you're doing great. You're really doing an amazing job. Okay, now I can sit down. It's an important speaker. Important speaker.
You want the clicker, or can I have control?
You can have control, sir. You can. You can. Look.
I'm surprised at that answer.
I don't know.
All right, I got the clicker.
Woohoo! All right, you can click one over. Let's. I want to look at how we got here and back up a second, okay? So the ACA passed during the Obama administration, and the ACA, we all know about the Affordable Care and lower. But they said, how are we going to do this, right? What are the goals? The goals are, for those of you who know, the triple aim, which is we're going to lower the total cost of care, we're going to improve the health outcomes of total populations, not individual patients, and we're going to improve the patient experience, the journey. The fourth point that some of us would love to see in there never made it, which is also improving the provider experience, but I try to keep that in the back of the mind, right? Because without our providers, we cannot do anything that we do. So these were the goals that the ACA set up. And kind of in a last-minute move, people said, wait, we don't have any way of moving to this. And so Congress authorized CMMI, the Centers for Medicare and Medicaid Innovation, which really became an incubator to test and trial models to see how we can reach those goals. Keep this in mind, it was to trial it, not to promise it. So during the time, CMMI, who was authorized by Congress to now have a bunch of money to do alternative payment methods, rolled out over 50 different models. Of those 50 different models, less than 6 reached any of those 3 goals. So when we get upset, which I've been in the trenches, so I get pretty upset when there's changes in models, we need to remember that these were a trial, and we kind of failed, right? We saved money, but CMS did not save money. And so the whole point from CMS's view was we need to deal with that trust fund so that Medicare is still around. And we saved money on a patient basis that Medicare Advantage, who I love, and other value-based contracts receive money back, but at the end of the day, CMS looked and said, wait a second, we actually haven't saved any money. The spend is still going all the way down. The other is that with attribution for those of you who don't know, works where you say, this is the payer provider, whatever it is, MA or an ACO, and then these are my docs, and my docs say these are my patients. And then because of that, the patient becomes attributed to the plan. Now, I know this is gonna be a little shocking. I call them the health nomads. You know, the 10, 20, 30%, we don't actually know the numbers, who go to the ER, right, 10 times a year, who go to the ER because they don't have heat in the house, who go to the ER or acute care because their fridge isn't working, and so therefore their insulin cannot be kept in the house, who don't have a primary care doctor, who don't go for a wellness visit, which is super important. We're talking 10, 20, 30%. Magically, those people have never been attributed. Why have they never been attributed? Because you have to go to a doctor, and for the doctor to say, this is my patient, this is my beneficiary. And so when CMS has been looking at sort of like what we've done well and what we haven't done well, with the same goal in mind, which continued through multiple administrations, they said, we actually haven't served the population that was left behind 15 years ago before we did all of this. And that's called health equity. So what it means, I'll give you like my little analogy on value-based care. So fee-for-service is you fall on the sidewalk, you break your arm, you go to the hospital gets paid for the service of fixing your sickness, and that's all the money. Value-based contracting says you are going to get paid to fix the sidewalk so that the entire population doesn't fall. Health equity says that sidewalk has to be in every single neighborhood. That sidewalk needs to be accessible. It needs to have access for the people who don't have access to health care. So CMS does not know how they're going to reach this yet. But the Biden administration has stepped back. They stopped all the models in the spring, which was a little devastating to some of us in the trenches, any of you who have spent millions of dollars the past 2 years preparing for certain models, and the models just went away this spring, you kind of know how painful that was. But remember, like somebody called me at one point, they're like, whoa, you should sue the federal government. I'm like, first of all, that's a little crazy. Second of all, they never promised to keep the models. They're like, this is an incubator, this is a test. But in their rollout, they've said it has to have equity, which is going to change completely. They've also said, and I know you guys have heard for a long time, value-based contracting's coming, you better be ready. 2030, mandated value-based contracting. By 2030, every single provider needs to be in an accountable contract.
And every member should be attributing.
They have to attribute, and you know I love attribution. The other is that the private pay, the self-pay employee plans, which if you guys don't know, that's 60% of all people covered in the US. They have stood up, I was there a couple weeks ago, the head of their organization said, we're not waiting for CMS, we're going forward this year and negotiating direct contracts. So you may want to wait for the next 6, 7 years, but if you don't negotiate the contracts, think about it, with the No Surprise Act, you're going to have to negotiate in-network versus out-of-network. With the employer self-pay plans, which is a huge amount of your money, you're going to have to negotiate now. And down the pike, over the next few years, you're going to see, just like EHRs, where they became mandatory. And I tell people it's like the same thing. People are like, well, value-based contracting, we've been talking about it for years, not really going to happen. Do you guys remember when we didn't have computers? Right? Because I do. I remember being like at a Christmas party with some surgeons, and I'm like, the thing is, you're really gonna have to move towards computers. He's like, I don't understand. We have a computer in the office. We don't have anything else we have to do, right? And interestingly, for those of you who follow the super complicated quality measures, which FYI, they've gotten more complicated. I know you're super excited about that. We have entered in a whole bunch of new quality measures that are going to cause whether or not you're paid or not. They have still entered in whether or not you have a working EHR that conforms to what they need you to do, which means some people don't, right? But if we remember that year when EHRs, anybody who's as old as I am, one year, all of a sudden, everybody had to put an electronic health record in, right? Remember? It was like, oh my gosh, how did this happen so quickly? And CMS said then, and they're saying again, we told you. We told you for years it was happening. Shame on you for not being ready. So what are they saying about value-based contracting? We told you. We told you. And you think the 20% pay cut is uncomfortable? A little bit. You got too comfortable in fee-for-service. So while it's taking us, meaning CMS, not me, some time to put this into effect, we're gonna make you super uncomfortable. So your docs are gonna get paid less. Uncomfortable? A lot of you are gonna be in the next 60 days when you start opening up the checks and seeing. So the thing is that you can wait until it's completely mandatory, or you can start following what they're doing so that you can be ready. So you can go to the strategy. So the Trump administration actually, value-based contracting, FYI, is the only thing that both sides of the aisle agree on. Right. So we hear that, value-based contracting went away during the Trump administration. Not at all. When he and his administration argued about the ACA, people went up to him and said, and his people, and said, what about CMMI? CMMI doesn't exist without the ACA, and you, meaning the Trump administration, created direct contracting, which I love. I love capitation, and I don't have time to tell you why, so you can either count on why it is, or you can ask me after. But, so he had invested a lot, the Trump administration, in direct contracting. And people said, well, how can you abolish the ACA and yet still keep what you wanted to do? He said, I didn't mean CMMI, right? We don't want to do away with CMMI. So what do we have? We have the only thing that both sides of the aisle agree on is good, which, tells us something. So the Biden administration came in, and the Biden administration said, we've got 50 models, they haven't all been so effective. We, meaning they brought back a lot of people that I have mad respect for, who've been working on this for 15 years, came back to work in the trenches again to try to see this through. And they said, we gotta pause for a second. And I'm sure all of you, it's hard when the federal government just stops things that we've been working on for a long time. I mean, I don't know how many of you have been involved in DISRIP, but I was there in DISRIP. March of 2020, two things happened. Everybody talks about the fact that we went into lockdown. I also talk about the fact that DISRIP didn't get reauthorized, and we lost our whole Medicaid reorganization, which was devastating, right? Because we had amazing maternal programs, and we had amazing, incredible programs. So that got paused, but CMS says, in order to do this equity thing, we have to do something about Medicaid. We have to do something about dual eligibles. And so you're gonna start seeing 100%, I'm telling you, you're gonna start seeing models that directly affect your Medicaid access beneficiaries and your dual eligibles, and people who you think are being paid through IHS or VA that are now gonna be required to bundle in so there's multiple payments. So you're gonna see health equity. You're gonna see more accountable care contracts. You're going to see more Medicaid. So they want to see more innovation and they want to see more partnerships. Now the partnerships I think is really interesting for you because I have thoughts, but I gotta tell you, I attend all the federal stuff and they're talking about like states that are rocking it, and they're talking about Massachusetts, and they're talking about Maryland, and they're talking some about California. I mean, a lot of meetings, and they've never mentioned Arizona. And I look at the numbers, and you guys actually are. So whoever like pays attention at the federal level for the state, like I would let them know that the feds need to know how good you guys are doing on paper. But you're going to see a lot more partnerships because the truth is that they know what you have to accomplish, but they really don't know how to get there. And so they are asking again and again and again for us in the trenches right now in the next few months to provide them with solutions, to give some models, to give more communication, to show things that you're already doing. And there's money for that, but there's also some freedom that I want you to think about, right? Because when you participate with CMS, you do get at least a couple of years, not only more money, but of some freedom to try stuff out. And I think you're gonna need that. You're also gonna see, if you think about it, whether it's health equity or whether it's accountable contracts, that you're gonna see a major shift in data. And again, I know, like, I've been interviewed on this for years, you know, the whole concepts of like interoperability, and I don't think it's ever gonna happen. But I will tell you that, and building off of your HIE, which would be my suggestion, you are gonna be required to provide a lot more data in the next few years. And that data is gonna have to be right. And I've been in a lot of your shoes, right? And I know that we're only required before to say 50% of our beneficiaries, what the race is, what the gender identification is. That's changing, right? And I tell people, like, if we don't know a gender or race, how can you even ask us whether or not, you know, we're reaching benchmarks or something like that? Like, we don't even know what color somebody's skin is that we've been treating for years. And CMS is saying, yeah, you're bad. Like, fix it, you know, good luck, but fix it. So we're gonna see a lot more investment in data, but we're also gonna see a lot more expectation of you in the field for being able to provide that data. And I think it's gonna come pretty quick, right? Because we're not seeing deadlines yet on that, but you're gonna see more Medicaid, you're gonna see data needs, you're gonna see health equity, but there's also things that you're probably gonna see. So the direct contracting closed up in the spring and then they're gonna reopen it. They're probably gonna call it something else, but what it means is that we're gonna see more of these capitated models. Now, I'm gonna tell you guys something that maybe nobody tells you. All of these contracts, whether they're with an employer self-pay plan or whether they're with an MA or whether they're with whatever, just fill in the blank, you actually can negotiate all of your rates. And FYI, anybody who tells you they can't afford to pay you what they were paying you, that's not accurate. I have worked with actuaries for years, and it has been approved to the actuaries. All of your providers can get paid more in a value-based contract than fee-for-service, not less.
Right.
And it has been a long time that we have been off the backs of our doctors and nurses who are doing the work to advocate for them. I've seen the contracts a lot of you guys get. And they say, look, there's nothing we can do. You want to contract with us, you're gonna have to take a haircut. You guys have heard the haircut?
Sure.
Right? You're gonna have to take a haircut. That is not true. CMS does not require them to do it, and I have done the math with 2 actuary teams to make sure I was correct. The total cost of care can be reduced in redundancies and inefficiencies that do not hurt your doctors, your nurses, and your facilities, okay? So work on that, right? You're the biggest advocate your doctors, nurses, and providers have. They're looking at you, particularly as you're looking at expanding, right? You can do that for them, and people need the contracts. You know, maybe we're gonna have to.
We can lower our rate or lower our utilization, but not both. Don't ask us to do both.
Right?
Right.
And the thing is that There's so much, and I'm a payer provider, there's so much waste in inefficiencies, right? All you have to do is stop the person from getting the same x-ray twice. You don't have to, because primary care makes up 4 to 6% of the total cost of care. And people love to cut at that. Like, no, we're gonna pay primary care less. That leaves, for anybody who doesn't know the math, over 95% of the costs that have nothing to do with your primary care doctors and nurses. All right? So while they talk about holding you accountable, you hold them accountable.
Hear, hear.
You say, I'm fighting for my doctors and my nurses. I believe in value-based contracting, because I'm telling you you do. Right? But I also believe in taking care of not only our beneficiaries, but our providers. So I want to go to some of the things that we're likely to see also. They want to build, look, Medicare Advantage is at about 50% of total beneficiaries, give or take where you are. That's probably going to plateau. I'm sorry, I know people. But the other is that CMS is coming down really hard on risk scoring. Like, really hard. They've gotten into their mind, I gotta go. They've gotten into their mind, I know you wanna see more of me. But, so we're gonna see a lot more building on the shared savings model, which seems like years ago, but we're gonna see more of that. We're gonna see more building of models that, from the federal government's viewpoint, have worked for them. So it really is an exciting time, or not. But it's a time, and it's definitely happening. Thank you so much for having me. I'm like so happy to be here. I'll be around the rest of the day.
Thanks,
Thank
Gail.
you.
Awesome. Oh, Scott asked Gail what her company does. Gail, you want to grab the microphone?
So, WiseCare supports value-based contracting. So we work with all the models, we support all of you who are doing the hard stuff, we do the math, we do the numbers, we help you with relationships, we help support from behind the scenes so that you can do what you do best, right? 20% of your time is spent on administrative burden. Let us take care of that for you so you can do what you really need to do, which is the real work.
Excellent, thank you. We really appreciate everybody coming out. It was a great day. Thank you very much for joining us.